And now we move on to none other than Dr. Chang, and he will be highlighting his talk on sulcus fixation. Over to you, Dr. Chang.
All right, well, thank you. That's a tough act to follow. Sunpec surgery is so masterful. So I'm going to talk about a different situation where you don't necessarily know you're going to be in trouble because you just think you're doing a cataract surgery with pseudoexfoliation. I have no financial interest in this talk. These are some of my textbooks that kind of cover a lot of this, and some of the videos are there. So as we all know, this is the problem with zonulopathy, pseudoexfoliation, is it's not enough just to get the lens in the bag, preserve the capsule. That's hard enough. We then have to worry about late bag IOL dislocation with this contracted capsule 7 years later. Now look at this case where I inadvertently aspirated the anterior capsule, and I created a zonular dialysis. I think it's about 4 o'clock hours, so I'm going to put a CTR in. And I'm bending the CTR and trying to, and then all of a sudden I see the equator of the bag, and now I'm seeing like 5, 6, 7 clock hours of the bag. And so now, not only have I trapped the cortex in the bag, but look what's happening when I strip the cortex. I'm stripping the zonules, what's left, everywhere else, because that CTR is transmitting the force of what I'm doing with my instrument to all 12 clock hours of the zonules, which are deficient. So the CTR works against you when the majority of the zonules are deficient. It helps when the majority of the zonules are okay, and you can leverage them for the 3 or 4 clock hours that don't work. So that's the problem with the CTR by itself. So this is going to be, this is an older case, and I think it's about 2005, but it's what I call my index case, and I'll sort of go through why I did it. So you're going to see a little halo here, because when I indent, I'm having trouble incising the capsule. That little light reflex, like a halo, could be because the needle's dull, but in this case it's because the anterior capsule isn't taut. So it's wrinkled a little bit. These were the capsule retractors at the time. This was the 2nd generation from Dick McCool. And so I'm thinking, well, I know how to do phaco chop this way. I'm not pushing the nucleus against the capsule. I'm using the phaco tip to support the nucleus. And those 4 capsule retractors act like artificial zonules. So they keep the peripheral capsular bag from coming toward the phaco tip. Here, the capsule isn't taut, so it doesn't want to separate from the cortex. I'm missing the zonular counterfixation that holds the capsule still as I try to gently strip the cortex away. What I would do nowadays is put in the dispersive viscoelastic to put the posterior capsule in stretch, but here I'm just doing it very carefully, and then I'm going to put in my CTR. Now, I leave the capsule retractors in place because I know that there's a tendency for the ring to push the bag around, and I'm also using the secondary fixation, using my Lester hook to bend it. And with the monofocal, you see there's a bleb to the right. I like using a 3-piece because why not? You get a little more compressive force than a 1-piece. And being compulsive as I am, I'm actually enlarging the rexus here, because there is a tendency for that capsulotomy to contract, and if you keep it large, it will not do so. I don't think you need to go this large, but certainly don't leave it small. So I've kind of done all the things I know how to do, and I'm feeling really good because they got a bleb, we had this weak zonular case, and it looks beautiful now, right? So now this is usually when people applaud in the audience because I did such a good job. But there's still one thing I can do to screw this up. And what do you think that is? Yeah, well, I decided I'm curious, I'm going to shake the eye. And all of a sudden, oh my God, why did I do that? This thing is completely loose. The bag is loose. And so here I've done perfect surgery. I got it in the bag, got the CTR in, and it's loose. So kind of in the audience, I'm going to give you a couple choices here. Leave it alone. you know, you saw a beautiful illustration of how you do scleral fixation. We could do the CTR. We could suture the haptic to the iris. We could move the sulcus, put in an AC or iris claw lens. So how many people would do number one? Just raise your hand. Nobody would leave it alone, because that was, all right, one person, all right. How many would suture the CTR to the sclera? You just saw some great demonstrations that only one. Okay, so you're running out of choices, two people, okay. How many would suture the haptic? We actually have a haptic here to suture the iris. Then we don't, you know, okay, we have two people. How many would move it to the sulcus? 5 people. That means everyone else would take everything out and put an AC lens in, right? Because everyone else didn't vote. All right. So I am at a loss, and I'm thinking, God, it'd be nice to leave this alone. But if I saw this patient 5 years later and they said their vision had changed, and I see this type of pseudophacodenesis, I just know it's a matter of time before it's going to shake completely loose. So I'm going to move it to the sulcus. Now, it's a little hard because I put in a lens that has posterior angulation. And so trying to move the haptic from the bag upward into that space between the anterior capsule and the iris is going to be really hard. So the only real way I can control this to go in the sulcus is to move this lens into the anterior chamber. So that's what I'm doing now, and I'm sort of using my other hook as a ramp to bring both of these up. And then once both haptics are there, then I'm kind of used to this one haptic at a time, going just under the iris. Now I did enlarge my rhexis, which now I'm regretting, but I just carefully have to make sure because I want both haptics in the sulcus. And now I'm going to dial this one in, and this displacement of the IOL tells me I'm in the sulcus, because with a bag I wouldn't be able to do that. And so I've moved it. It kind of looks the same, but I have moved the location, all right? So what next? Someone suture it? All right, someone's doing this. So how many people want to test it and jiggle it? How many would jiggle the eye? Okay. How many people that this is like, we've done enough, we don't want to know anymore, would not jiggle the eye? Raise your hand. How many people would not jiggle the eye? Okay, yeah, you know, this is how we do it. How many people you wouldn't jiggle the eye, but you want to see what happens if I jiggle the eye? That's what usually happens. So okay, so here, jiggle the eye once. So I'm going to jiggle the eye, and look what happens. So, wow, this is great. Now, why do I call this my index case? Because this is only one case that I don't have a lot of follow-up. I'm here on the operating table, but this is very unusual. I have put the same lens in the same eye, and I've shown you what it looks like in 2 different locations, one in the bag and one in the sulcus. And there's a dramatic difference. And this, to me, proves something must be going on. I must have 2-point fixation between the haptic and the ciliary body. And I kind of call this belt and suspenders. Normally we use the belt, which is the zonular ligaments circumferential to hold it. But in addition, I have these 2 points fixating like suspenders on my shoulders. And that's what does it. Now, okay, that's an old case. That's index case 1. This is index case 2. Here's another case where I've done this. Look, I'm jiggling the eye. It's a bad habit I have, but I'm jiggling it. And there's gross pseudophacodenesis. So there's a CTR in place. And it says, I've been here before. I wonder if I move this into the sulcus. Same thing, I have to use the Sinskey hook as a ramp, bring that haptic up into the anterior chamber. Okay, all right. So, you know, one of the things I could have done is I could have put in a capsule tension segment. Sun Peck showed a really nice, you know, how nicely that works with her Gore-Tex Hoffman pocket. But I've moved it into the sulcus now. The rhexis is smaller. I've captured it. And this is just to show, again, same lens, same eye in 2 different locations. And the pseudophacodenesis went away when I put it in the sulcus. So with that first index case, and with that, I now do this all the time. Now here's a case where I've got a nasal zonular dialysis due to trauma. So I've pulled this out. I've put my CTR in. And so what I'll do now is I've got zonular dialysis nasally, so I should orient the haptics 90 degrees away from that, right? But if I have to capture the optic, because if I don't, it's going to rotate in the sulcus. That haptic will go through the zonular dialysis. And what's different here, let me just go right back to here. You know, we're used to doing this when we have an open posterior capsule. We put the lens in the sulcus, capture the optic. But it's different when you have a bag because the viscoelastic will get caught there. So I have to vacuum out a little bit of it before I then plop the optic through there for the optic capture. Otherwise, what happens is that trapped OVD will sort of push the optic forward, and you'll get a myopic surprise. And the way you get out of that is I'd have to yag the posterior capsule, and that would then let the OVD bleed out posteriorly. Okay. Now, here's another case where there was diffuse zonulopathy. The capsule retractors helped me, and I think this rhexis is a little bit too small. So in order to do this technique, I'm just going to make a secondary little oblique cut and then secondarily enlarge it. These are MST capsule forceps, and they're very controlled, and I love being able to go through a paracentesis site so I don't burp out the viscoelastic, causing the chamber to shallow. And I think you can see here I'm trying to put viscoelastic to open up that space in between the iris and the anterior capsule, and this again lets me get into that space. So it is important that the rhexis isn't too small. Once in a while the zonules are so bad I can't capture it. The bag wants to go back too far, and I would leave it in the sulcus. And I like using this AR40, it's a J&J lens, because of all the three-piece acrylic monofocal lenses. It's the one that has a rounded anterior edge, so that if it for some reason had to be left in the sulcus, I'm not going to get iris chafe. So this is that same step. You have to do this, is to go in and just aspirate. You don't have to get all of it, but what you can of the OVD that's behind there, because once we buttonhole the optic, it's going to be trapped there and it cannot come out. But you see that lens is in the sulcus, it's decentered. I think here I'm trying to rotate it. If I can get the haptics to 3 and 9 o'clock, I think that's probably going to help, because a lot of times, you know, when we shake our head and move our eye, that's the orientation of the saccadic movements. And then there's the optic capture, and then I'll retract that there. Okay? All right. So what's nice about this is if you don't have the hardware there, because you're doing a pseudoexfoliation case, you're not sure, you didn't anticipate this, and I got through this, this is a way that, wow, I can just put this in the sulcus. All right. So why capture? Well, you now have a way to, there's a CTR in. I do think you want to have the CTR in. It sort of reduces peripheral stress on the zonules, but this will prevent capsular rhexis contracture. If the rhexis is centered, then your lens will be centered. It does prevent rotation. I showed you a case of a zonular dialysis, but even diffuse zonulopathy, you don't know if there's an occult dialysis, and if it's just in the sulcus, it might rotate, find its way through there, and you get a late decentration. A nice little benefit. You don't have to change the IOL power, as you know, when you do optic capture. Well, here is a capsule tension segment. This is an older video. In this particular case, I'm using at the time a 9.0 Proline, just another way to do it. This is before Rich Hoffman described the Hoffman pocket. And I'm going to make a little scratch groove and try to line this up with the zonular dialysis. So instead of a trocar, I'm just putting in a paracentesis on the opposite end so I can externalize the needles. And then here's the guide needle, and one is going to go over and one is going to go under. But I bring the needles to the other side so I can just shoot it across, but with that half thickness scleral groove, 2 millimeters posterior to the limbus, I'll be tying the knot and it just falls in there. So I do have to take down the conj, and so that will go in there. But then I'm going to put the IOL in, and again, this may be enough, but belt and suspenders. Maybe the belt is enough, but if I really want to be sure, and it's a monofocal lens, I'm going to put this in the sulcus. So again, don't want to cinch it up too tight. This is, we don't have this lens anymore. Again, it's an older video. Star used to make this 13.5 millimeter overall length silicone 3-piece lens. And so I'm putting this one into the sulcus and then capturing the optic, even though I have my CT segment. What would you do with this case? It's a brunescent lens, pseudoexfoliation. I'm starting my rhexis. Whoa, the lens is spinning already, but I kind of keep it small and just gently try to continue that rhexis. You can see it's a black. Whoa, wow, that's moving a lot. All right, so I guess I do have a decision point here. All right, so how many people would just start phaco at this point? How many people would do a CTR and then start phaco at this point? How many people would put the capsule retractors in first and then start phaco at this point? All right. How many people would just stop and refer at this point? Any other choices? Hooks and CTR. Do everything. How about CT segment and CTR, right? Any other choices? Extra cap, yeah. So now with something like this, so I'm not the best at SICS, and this thing is huge. So at this point, and this is like a hand motion eye, I'm just going to abandon my temporal, that's converting to a can opener. I've gone superior, going to abandon my temporal clear cornea. You could do SICS, but this thing is so large, I just want to get it out. So I'm just going to do a conventional anterior limbal incision. I'm not going to worry about taking extra time to suture, and we're definitely not going to worry about cylinder in this hand motion eye. So this is, I think, an underutilized technique, especially in the West and in the US, where residents don't get trained how to do this anymore. And we don't have as many rock-hard cataracts, but there's a couple benefits, okay? Because if I was to do phaco, it's going to be really hard on the corneal endothelium. Certainly, depending on your experience, a lot greater chance of PCR, retained lens, vitrectomy, retained lens material. Okay, look at that lens. You know, you don't see the lens when you phaco it because you dissect it apart. But notice there's some viscoelastic on the top, but the top is like flat, like on a table. And the bottom is concave, like a rice bowl or a soup bowl. So this is kind of interesting. Thank goodness the front is flat. That's how we can complete a rhexis. It would be hard if it was upside down. And it tells you why it's so hard to chop through that and why it's so hard to crack, you know, when you do divide and conquer, all right? So at this point, I've done my INA. I'm going to put in a 3-piece non-foldable monofocal. But here's the point I want to make. So not only did I get the lens out, but I don't have to worry about this lens decentering because there really isn't a bag anymore. And I don't really know whether the haptics will both be in the sulcus or one P-pod's out, but I can guarantee you one of those haptics, if not both, are going to end up touching the ciliary body. So I have basically created sulcus fixation, and I don't have to worry about a CT segment or any of the other hardware. And that's the benefit you get with an extra cap, okay? Because all the years we did nothing but extra caps, we never had this thing of late bag IOL dislocation. That all happened after the capsular axis, okay? So if we have one more second, I've showed this a couple times, but look at this. This is actually a dead bag syndrome. Look at this huge zonular dialysis over here. And so this is the problem with the CTR. This is Dr. Shimawaki's innovation. He's from Japan. And this is sold through Corsa. Corsa is on the exhibit floor. And it has this fixed hook in the front onto which you drape the lead eyelet. And so when I open this up, the lead eyelet doesn't go in the fornix. It stays right in the center and it opens like a spiral, and it's really, really slick. To disengage, I'll turn everything slightly to the right, and that lead eyelet will fall off first, and then the trailing eyelet usually falls off second. This is obviously reusable. So it only just got, and it's really nice when you have capsular retractors already there, because as you know, this kind of runs into the retractors. You run into these other areas sometimes where the bag has a fold. You avoid all those troublesome areas by the lead eyelet not having to go there. So it's not, you can purchase it and put your name on and order it, but it's not actually yet available in India. And in the United States, it only kind of became available in December, January for orders. But I use this on every case now with a CTR. It's so slick, and it's such a neat idea. So thank you very much, and thank you, Priya, for inviting me.